All right, heart failure. Heart failure is the inability of the ventricles to pump enough blood for the body's needs, which is the result of weakening heart muscle due to aging or the disease process. So there's several diseases associated with heart failure, including coronary artery disease, mitral stenosis, myocardial infarction, which is another name for what? Heart attack, right? Diabetes. And there's no cure for heart failure, but we can slow the progression of heart failure. So there are two different types of heart failure. There's left-sided heart failure. This is when blood accumulates in the left ventricle, where the left ventricle thickens and enlarges and causes hypertrophy. We see cardiac remodeling, blood backing up into the lungs, and this results in coughing, shortness of breath. We see tachypnea, crackles, cough, cyanosis, fatigue, tachycardia, restlessness, and some confusion with left-sided heart failure. We think of these people as blue. They're leaned over and they're blue. Whereas right-sided heart failure, the blood backs up into the veins, resulting in peripheral edema, organ engorgement, and it occurs less common than left-sided heart failure. With right-sided heart failure, we may see ascites, enlarged liver, spleen, weight gain, dependent edema. That's when we see the distended jugular veins. Okay, so we look at two different areas. We look at preload and afterload. And so they both affect cardiac output. Let's talk about preload. Preload, we look at the degree the myocardial fibers are stretched prior to contraction. This has to do with the Frank-Starling law. And we have drugs that increase the preload contractility and thus will increase cardiac output. And that's our goal. What it is the left ventricular is so weak that it's not pumping effectively, so there's decreased cardiac output. And so the preload contractility will have a positive inotropic effect and will increase the amount of cardiac output going out. And then we have afterload, which also affects cardiac output. This is the pressure in the aorta that must be overcome before the blood is ejected from the left ventricle. And lowering blood pressure creates less afterload, resulting in less work of the heart. So our mechanisms of the treatment of heart failure include slowing the heart rate, increasing contractility, and reducing the myocardial workload. So how do we know whether or not somebody is in heart failure? And certainly we can look at the signs and symptoms that they have and determine whether or not it's left or right heart failure, but how we actually diagnose this is doing an echocardiogram. And an echo is an ultrasound of the heart, and we measure the left ventricular ejection fraction. So normal ejection fraction would be about 50 to 75%. Impaired function would be less than 40%, and folks start becoming symptomatic of heart failure at less than 30%. Congestive heart failure is diagnosed right at 40 ml. All right, the role of the nurse is to obtain the health history, assess vital signs, urinary and cardiac output before and throughout therapy. And with our heart failure clients, a priority is to monitor the amount of fluid that they're taking in. These folks have fluid restriction. We're also limiting the amount of salt that they can take in because the salt attaches to the water and they stay together, so we wouldn't want extra fluid volume. All right. So how the lecture has been organized is I've introduced the class of drugs where we talked about them, and in each area where we use these drugs, I've talked about them again. But I don't go back and talk about everything with ACE inhibitors because we had all that in our hypertension lecture. So ACE inhibitors, remember these are the ones that end in pril, right? As related to congestive heart failure, reduce afterload. They are our first-line drug of choice for heart failure. They enhance the excretion of sodium in water. They lower peripheral resistance and reduce blood volumes, which thus increases cardiac output. These drugs are like lisinopril. Remember, ends in pril. Here, in the treatment of congestive heart failure, they inhibit ACE inhibitor inhibits the ACE enzyme and decreases the aldosterone secretion. which thus lowers the blood pressure, reduces blood volume, dilates veins. All right, remember we have that transient hyperkalemia associated with our ACE inhibitors. Also, we have to worry about angioedema and that non-productive cough, first dose, or the static hypotension. And with Capril, we have associated with the neutropenic effect. All right, moving on to angiotensin II receptor blockers. Again, they work very similar to ACE inhibitors, used for patients that are not able to tolerate the adverse effects of ACE inhibitors. So maybe they had angioedema associated. No, not angioedema, because angioedema is contraindicated when they've had an ACE inhibitor. This is maybe if they've had that cough. We also use diuretics. We've spent a lot of times talking about diuretics. They increase the urine flow, reduce the blood volume and cardiac workload, reduce edema and pulmonary congestion, and prescribed in combination with other drugs. The role of diuretics, assess renal function. Remember, our loop diuretics will work in the face of renal failure versus hydrochlorothiazide. If there's any sort of renal problems, that's not the drug. It won't work. Monitor electrolytes. We're particularly worried about what electrolyte? Potassium. Monitor blood glucose and BUN. Monitor sodium intake, report weight loss, report fatigue, muscle cramps, and to change position slowly to reduce orthostatic hypotension.